this speech is going to deal to a subset of patients who, besides having chiari-1 malformation, also have something else. In this case, anterior pathologies. It is estimated about 1/4 of the patients with chiari-1 malformation have different degrees of anterior pathologies. For anterior pathologies, we deal with everything which is in the anterior part of the foramen magnum, which is exactly in the back of your throat. They can affect different bony structures. Anterior pathologies are a long list, and this is just limited to the very, to the top headers. Often, what is responsible for this anterior compression is a number of congenital bone malformations and connective tissue disorders. And whenever there is an association of chiari plus the anterior pathology, the clinical presentation of the patients tends to become more complex, more diverse for the number of the symptoms and the neurological signs, and also more dramatic in degree. This speech is just going to deal with our recent experience. Dr. Rekate joined the Chiari Institute in 2010, in January 2010. So from that point on, we did 138 consecutive surgeries on these patients who were sharing two pathologies, the chiari-1 malformation, the anterior compression. 101 were done with traditional techniques, and 37 with a new technique I'm going to describe in the second part. How do you measure this anterior pathology? For the chiari-1 malformation, everybody has followed the first speakers. There is a way to quantify that. There is also a way to quantify the anterior pathology by using different parameters. The rule of thumb is there are about 24 of different parameters to characterize the anterior pathologies. The rule of thumb is you pick at least two. So you're looking at the same problem from two different perspectives. The two sexiest parameters right now, the most trendy, are the Grubbs measurement, which was mentioned this morning, and the CXA, which is an angle between the clivus and the second vertebra along its length. Whenever you have Chiari plus an anterior pathology, I keep repeating it, you have two pathologies in one. And therefore, what you need to fix it whenever the patient is symptomatic enough and their life is bad enough, you need to do two surgeries to address two pathologies. These surgeries can be split in two different surgical sessions, so you do a stage procedure, or you can do it in the same time in what is a combined procedure, much longer than ordinary. The two surgeries in question are posterior fossa decompression, obviously to treat the chiari-1 malformation, and the cranial cervical fusion with odontoid reduction. You remember this morning the pictures by Dr. Rekate, in which the odontoid first was crooked backwards and invaginated up, and by pulling the head backwards and pulling it up, he created a reduction. It is like reducing a subluxed shoulder and putting it back in place. We put back in place that bone, and we decompress the anterior part of the brainstem. So this is the couple of surgeries we're dealing with. If the craniocervical fusion is done properly and the anatomy is not that messed up, scientifically speaking, at that point nothing else is needed. But in some selected cases, every now and then, you need also to add a third procedure later on. First, you do the first couple of punches, the chiari decompression and the craniocervical fusion. You wait, you see how much the structures change and shift in place and over time, like Dr. Heiss was showing, and then you see if you need to do more. And this more is quite rare in our experience. Dr. Rekate had to do it just a few times, a handful of times in over 10 years. I had to do it only 3 times during the course of the last 12 months. The dilemma of these two surgeries is that, first of all, you do it together, you do it combined. It's, there are proponents of one or the other. We prefer to do it combined. The major technical problem is that the posterior fossa decompression, the Chiari surgery, and the craniocervical fusion, the anterior pathology surgery, compete for the same real estate, which is the supraocciput along the midline, which is that part of the back of the head where you keep seeing today that we, the neurosurgeons, keep drilling holes and making space. Now, both of these surgeries want access to that area for different reasons. The Chiari surgery wants to remove bone. Okay, everybody understands that. While the craniocervical fusion needs to add bone. And you cannot really do two things at the same time. So you start compromising and shifting. Okay, I'm going to remove a little bit more, less bone with the Chiari, so you can leave more space for the fusion, etc. The other thing is that the craniocervical fusion, in order to work properly, needs access, wide access, to thick occipital areas. And this is the other problem. Very often with the Chiari-1 malformation or Chiari anomalies, the cerebellum is trying to escape from the skull because it's all trapped like Count of Monte Cristo, and so it erodes the bone from the inside, so you can have these potato chips, thin skulls, and putting a screw which is 10 millimeter long in a skull which is 1.5 millimeters thick raises some technical problems. Obviously, you cannot put it there because the brain is not very tolerant of screws that are stuck inside it. Plus, the other problem is that if you do one surgery and you're sabotaging the other one, you cannot shortchange either of them. So the posterior fossa decompression cannot be shortchanged in decompressing the Chiari while you're leaving enough bone for the craniocervical fusion. So these surgeries, which done by themselves would be a walk in the park, and they can be done in many different ways, especially the Chiari. Once they're combined, they're raising a lot of technical problems. So this is a typical, the drama of the spinning is just to make it more interesting after lunch, so you guys wake up. But everybody can see over here a classical bony decompression for a Chiari and a C1 laminectomy, which is pretty much what most of the neurosurgeons would do. And this is the area where you want to do also your craniocervical fusion. You know this guy? And he is my mentor, partner, and boss, Dr. Rekate. My former mentor and boss was Dr. Mirat. Everybody knows of it. And he has his technique to deal with these things. I have my technique to deal with things. His technique is very traditional. He does a craniectomy and a C1 laminectomy, like to show you this morning. He does duroplasty. I'm not going to repeat what he said. Whenever he has, this for the Chiari business. For the decompression, he does a standard craniocervical fusion with screws in the back of the skull, obviously where the skull has not been removed, screws in the first vertebra, the second vertebra, and they're kept together by two bars, which are 12 to 15 centimeters in length. We're going to see it very shortly. But the other two things, he uses the bioplate, the same way that Dr. Bassov and Dr. Holly use. And he also uses, because he got infected by me, the color Doppler ultrasound to check about what happens to the cisterna magna for the Chiari business, and what happens with the compression between the odontoid and the cervicomedullary junction during the surgery. So if we relieve the compression during the surgery, we see it, we can touch it, we can measure it, and at that point we know that we've done our job. And we don't have to wait the MRI the following day to say, I wish I had pulled more or extended more or whatever. You can see it in the OR if you had done your job. This is how a standard craniocervical fusion means. I know it's like gruesome picture after lunch. If you have to vomit, please go in the back. This is the back of the skull, and this is the cervical spine. So what you do, you put screws in the spine, screws in the skull, and what does this contraption do? If the patient feels better by reducing the odontoid, you need to pull the head up and you need to extend the head backwards. And that puts that bone back where it belongs. The only thing is that if I do that to a patient, then for the rest of my life, I'm going to have to follow the patient like this. So what we want to do during the surgery, we want to reduce that bone, and then we freeze that position by adding all this hardware. Okay, this is like everything in medicine. You give something, you take something. You give relief, and you take away some range of motion. You give the relief from the odontoid, but you give these bars, which are pretty sizable, and they have a relief, so patients feel it afterwards. So these things is not void of side effects and problems of its own. This is the way it looks on a post-operative X-ray. So the nose is in this direction, the back of the skull is over here, and this is how a craniocervical fusion standard looks like it. Then you add a lot of bone, and you wait for this bone to grow, and it's going to take some months for that to reinforce. What you want at the end is a pillar of armored cement, with the metal being the titanium, and the cement being the bone. So you want two pillars, one on the right, one on the left, to hold up the head in that good position, which implied the reduction of, which had as a consequence the reduction of the odontoid. This is the way it looks on a 3D CT afterwards, and you see that the bars have been covered by these pillars of bone, which come from the patient's body. First, you put a matrix, which is a sort of a framework, and then the bone cells, they grow up, and they take over about 3 to 4 months. They form these two big pillars of bone. All right, that's one way to do it, but you understand that this is under the predicament that you have skull which is thick enough over here to take the screws. And that sometimes doesn't happen. So after doing it, this experience was from 2010 to 2013, but with Dr. Mirat, we had done these craniocervical fusions since 1999. So I had some successes, some failures, and the reason why you want to change comes out of your failures. When all the cases which have not worked the way you wanted. So after trying to think about it, I came out with a new approach to this problem, which is, let's try a way in which I cut the minimum amount of bone possible, as aggressive as I can on the tonsils, so I'm not shortchanging the posterior fossa decompression, and then I develop a fusion that is going to be independent from how thick how thick the bone is in the back of the skull, or how much skull is being left behind by the former surgeon, if I do a redo. So the new technique for the Chiari is that I do a very small craniectomy, the smallest possible hole to visualize the tonsils. I generally do not cut the C1 open, so I do not take a bite of the onion ring, I just shave the very top. I do a linear durotomy, which means that instead of making a Y-shaped incision, I just make one incision in the middle, very small, just enough to show me the tonsil. 2.5 centimeters is about 1 inch for you Americans. And then through that hole, I start doing a tonsillar shrinking, the same way Dr. Batzer was showing before in the videos with Dr. Holly. And then I push it a little bit more, and I do a sub-PL total tonsillectomy. Subtotal. Subtotal means that you're not cutting 100% of the tonsil, you're cutting away and sucking away about 75 to 80%. Tonsillectomies have been around for about 25 years, the first reported tonsillectomy. No, not that one inside the mouth, obviously, tonsillectomy for Chiari. And the tonsils have no function whatsoever. With that, I'm not saying that this is the way to do Chiari surgery. There is no single way to do Chiari surgeries. There are many ways to skin a cat. This is simply the way that I'm using for these cases in order to remove the smallest amount of bone possible and not shortchanging the Chiari to get my fusion done. And then, since I just buy so much space on the inside of the dura, I don't need to do a duroplasty. I just get away with cutting, with stitching the dura back together. So this is the way it looks. It's a 2-inch incision. A very small craniectomy. First, you drill it thin to a potato chips, and then you bite it away. This is the exposed dura. I check with the ultrasound that all my tonsil is exposed. I do a 2 centimeter long. This is 1 and 2. I go inside. I coagulate first the tonsils, but the inside stays medium rare, like a steak. So I slice them open, and I do the same inside, and then I suck and I cut all that tissue. And with that, I extend it up to 75% of the volume of the tonsil. Then, like an empty paper bag, I crumple together, and then I put a stitch in order to restore it. This is a trick from Dr. Batzdorf. And with that, we decompress the brainstem, we decompress the 11th cranial nerve, and we completely expose the bottom of the 4th ventricle. And then we close the dura. This is the tonsil before the surgery. This is after. We buy so much space, we don't need to do a duroplasty. So Dr. Holly before was showing you the space that has been codified by Dr. Bassov in his last article on the Journal of Neurosurgery, that the goal of the surgery is to restore the cisterna magna, like Dr. Recade was pointing out, by adding, and the landmark, the hallmark of a well-executed surgery is the restoration of cerebrospinal fluid spaces below the tonsils and behind the tonsils. Here, since we're cutting through the tonsils, we are, rather than increase infratonsillar and retrotonsillar space, you have a transtonsillar space because the tonsil, all this part here, has been cut away. So all this is the cisterna magna that we want to look for. Now, the other goal of the surgery is to reduce the odontoid. So we don't want the odontoid to be bent backwards and pushing against here. You want it straight, and you don't want any more compression here. So this comes the second part of the surgery, which is the fusion. And in order to compensate for all the other problems I was saying before, we do a mini fusion. The key for everything is, again, the same C1, C2 screws. The key is to put screws, instead of in the back of the skull, at the very base of the skull. At the very base of the skull, there are these two small, short pillars, very thick, but kind of not very tall, which are called the condyles, which are kind of allowing the head to glide on top of the first vertebra. And you can put something sizable in terms of screws. You can put between a 16 and a 20 millimeter screw. To tell you that the screws which are regularly put in a craniocervical fusion of the classical type, they range between 6 and 10 millimeters. So putting two 20 millimeter screws is kind of mechanically more advantageous. The other advantage is that since we're not riding so up, the length of the hardware is much shorter. So from 12 to 15 centimeter, now we're 3 centimeter of bars on both sides. So that allows to minimize the skin incision, which now becomes just 3 inches, 3 inches and a half, and minimize the dissection of the muscle, minimizes the bone, the pain. So all things that tend to be a little bit preferred by patients whenever they line up the right way. So this is the way that the beginning of a fusion looks like. This is the first vertebra, which is kept intact. This is the second vertebra, which is kept intact along with all these muscles and ligaments, this so-called biomechanical speakily tension band, so you prevent mechanical problems later on. And these are the two screws at the base of the skull. This is the very small craniectomy which was done. This is the dural closure, which is 2 centimeters in length. 2 screws at the base of the skull, 2 screws at the base of the first vertebra, 2 screws in the second vertebra. Just show you this, these screws are smaller than the tip of my pinky, so you have an idea about the size over there. Then we add 2 bars, one on the right, one on the left. We lock the bars into position with caps. And then we add the bone matrix I was telling you before, which is a ground-up bone of the patient plus ground-up bone of cadavers plus chemicals. And all this over time, and with the help of the biology of the patient, is going to form 2 bone pillars, one on the right, one on the left, which is going to reinforce the fusion. And you don't want to cover your decompression, so you keep all this clean. This is the length of the incision. You know how generally the ears are long, so you have an idea about how that incision is. And this is how a post-operative X-ray, post-operative CT scan, and this is in coronal, so it shows you how close the screws are to each other, so biomechanically it's more advantageous. And this is how it looks in a fancy-schmancy 3D CT later on. And this, again, the same spinning. Recapping. Anterior pathology are present in a significant amount of patients with cerebral malformation. Often, these pathologies cause clinical problem along with the chiari. There are a lot of parameters, and obviously there is a threshold about which these pathologies are significant, and the thresholds about which become surgically significant. Therefore, you have to do something for them surgically. These pathologies, the combination of these two things have been found out to be responsible for failure of a standard posterior fossa decompression in a subset of patients. Therefore, there is a small minority of patients with chiari bone malformation in which these two surgeries have to be done together in order for the patient to have the best possible outcome. Thank you very much.